Hi, I'm Stephen Strakowski. I'm the Joyce and Iver Small Professor of Psychiatry at Indiana University in Indianapolis, as well as I have an appointment as a Professor of Psychiatry and Behavioral Science at the Dell Medical School at the University of Texas at Austin. Today, I wanted to talk about a recent paper that came out that highlights an ongoing challenge for us in psychiatry, namely that there continue to be racial inequities in how we prescribe antipsychotics, particularly in people with mood disorders, is going to be the focus today. So I'm going to share a few slides just to help the conversation. This is the paper that came out. It comes from a very good group at Mount Sinai in New York, led by Dr. Medina. And what they were doing was using their large health system electronic records to look at prescribing patterns of particularly of antipsychotics in people with schizophrenia as the primary focus. And they found something that has been found for 30 years, that if you're Black and now Hispanic, you have a higher rate of being prescribed first generation rather than the newer second generation drugs. But in this conversation today, I really want to focus instead on their secondary analysis, which was in people with mood disorders, where the same types of inequities were observed, and for me are somewhat even more concerning. So to give you a kind of a background on this manuscript, like I said, this is from a very good Mount Sinai health system in New York City, and as I'll talk about, it's not unique to them, so it shouldn't be perceived that way. The investigators extracted over 200,000 records from their electronic health record with about 19,000 people with bipolar disorder, which is our focus today. So these are people who were all given clinical diagnoses of bipolar disorder in the record. I'm going to focus on just non-Hispanic, white, Black, and Hispanic individuals, as that's where most of the inequities were seen. And you can see in this slide, it's about 40% of the sample was white, 18% Black, and 14% Hispanic. Now, the findings were fairly dramatic in that if you were Black or Hispanic, you had a significantly higher risk of being prescribed first generation antipsychotics compared to white folks. And this included for haloperidol, fluphenazine, and chlorpromazine. And again, as you can see in this slide, the odds ratios or risks were around 1.7 to 1.9, which are meaningful and significant. And again, you can see the significance was very high. So this was not just a chance finding. And additionally, the antipsychotic doses when prescribed in Black and Hispanic individuals are significantly higher than white folks. And then there was an overall lower use of thymoleptics, specifically antidepressants and mood stabilizers. This manuscript did not report lithium prescribing, and I don't know whether that was because it was infrequent, and that's been a conversation we had in a prior Medscape video where in the United States, we probably significantly underutilized lithium for bipolar disorder, or whether because the primary focus was in schizophrenia, that it simply wasn't extracted from the record. Now, as I mentioned already, this unfortunately is nothing new. This inequity in medication choice in people with mood disorders generally and bipolar disorder specifically, if you are Black, has for 30 years had excessive rates of antipsychotic prescribing. Just coincidentally, last year, a similar large data set was examined by the group in University of Mississippi by Dr. Chikrizov and colleagues. And what they found was virtually the same thing as this Mount Sinai sample in two large data sets, one national data set and one local at University of Mississippi. Same findings, excessive use of first generation antipsychotics in people with bipolar disorder. And in this case, they did look at lithium, and there was a much lower rate of using lithium lamotrigine and antidepressants in the mood disorder sample. 20 years ago, our research group found virtually the same thing and followed a group of patients who had been hospitalized for a first manic episode, and saw the Black individuals were over twice as likely to continue to receive antipsychotics after discharge even in the absence of psychotic symptoms, and were again much more likely to receive first rather than second generation antipsychotics. Somewhat unsurprising, the adherence rates then were lower. And again, these drugs have side effects and they can be significant. And so it's something for us to think about as we consider the prescription of the older antipsychotics, which I'm going to again talk about more in a second. We also replicated this in an adolescent sample, so it wasn't something that developed over time in chronic patients, but it was true right at the beginning. There are dozens of other reports for the past 30 plus years showing this same general pattern in schizophrenia and mood disorders, where Black individuals are just more likely to be given higher doses, given antipsychotics, and given them at higher doses. Now in 2024, the real question is, why are these being prescribed at all for anybody? In the very good CANMAT bipolar disorder treatment guidelines from 2018, the only first generation antipsychotic mentioned was haloperidol as a second line treatment for acute mania, but it is not considered a good choice for maintenance therapy or treatment of depression. In the latter, it actually may worsen. And so its use, if there is an indicated use, it's limited, given the other choices that we have available now. My colleague and I, Paul Keck, in the recent Schatzberg and Nemiroff psychopharmacology text, recommended against using these first generation antipsychotics just generally, because of the problem that even if they're used, if haloperidol is used in a narrow way for acute mania, there's unfortunately a tendency to continue to prescribe the drug long past any utility it might provide. Additionally, these drugs, again, there's an assumption that the first generations don't cause the same metabolic problems, but for the low potency drugs, that's probably not true versus the newer drugs. And the high potency drugs, and all of them in general, have a much higher risk of extrapyramidal symptoms and side effects. And then sort of, as I think of them, non-reward side effects, apathy, amotivation, depression, because they're full antagonists in the dopamine system within our reward pathways. There's some old, largely not proven suggestion that the excess of smoking in these individuals is an attempt to override that block of the reward system. I can't prove that that's true, but it makes sense from a face validity perspective. Regardless, and most of us who are working specifically in bipolar disorder most of the time really do not recommend the use of first generation antipsychotics for long-term care, and generally don't recommend them at all because of the tendency for them to persist after they've been used for short-term care. Now back to the other question of why is this happening, that Black patients and now more recently Hispanic individuals are getting higher doses of these drugs and more frequently relied on? Well, there's unfortunately a racist background that arose out of Jim Crow and that got perpetuated into the civil rights era in the 60s, that Jonathan Metzl describes very nicely in his book, Protest Psychosis, where the diagnosis of schizophrenia during that period largely shifted from sort of quiet white individuals to being applied more and more often to Black individuals, particularly those involved with protests, and particularly at the South. Accompanying that then, as the antipsychotics came to market, because they were new back in those times, was a use of these then called major tranquilizers to manage what was perceived as aggression and hostility in Black people, which was almost certainly, and has been demonstrated, discussed by Metzl and others, to be a misperception based on stigma and bias. And so accompanying that was then an overdiagnosis of Black compared to white people with schizophrenia that we've talked about in a prior Medscape video. And all of that was leading to a bias that antipsychotics were specifically more necessary than Black individuals, in the absence of any data whatsoever ever suggesting that that's actually true. More concerning, not more concerning, but equally concerning, recently, there's been this increased use of these medications in Hispanic individuals. And I don't know why that's happening, but I have to worry that culturally there is this racist portrayal of people from Mexico, Central and South America as being dangerous and aggressive as these refugees are moving out of horrendous situations where they live to try to immigrate into the United States. This racist portrayal, not only is it inaccurate that these are mostly violent and dangerous people, which is simply not true, but it then gets perpetuated into how we think about taking care of these individuals. So how are we going to solve this? The good news, I talk about this a lot, is that the people I meet that are in mental health care, the vast majority really want to provide equitable care and are always unhappy when they see that they're not. Unfortunately, inequitable care has been demonstrated virtually everywhere it's been looked at. And so despite our good intentions, we still are vulnerable to the same biases as the rest of society. Again, since the Civil Rights Act, and certainly in healthcare, there's just really not been a good national strategy to correct these inequities. So as far as I'm concerned, it's really up to us. It's up to us to try to change how we think about how we care for people and keep these inequities in mind. And so how do we do that? How do I do that? The first is to kind of look honestly at your own biases and stigmas. We all have them. It is not possible to live in a society like the one we live in and not have them. And so we're all vulnerable to these. Look honestly at your practice, look at how you're prescribing, and then ask why. Why am I giving this drug to this person? Ask it again and again. There's the old lean method of performance improvement where you ask why 6 times until you understand why you're doing this. So why is this particular patient in front of me today with bipolar disorder getting a first generation antipsychotic? Because this is not a good, certainly long-term strategy. And so we really need to challenge it within our own practice. What were the assumptions that led to this prescription in the first place? Did I start it, or did someone else start it and I've just been reluctant to change it? I think there's often a belief that if everything's okay, we shouldn't touch it, but sometimes that's not true, because what is okay might be improved by removing something that's causing side effects such as amotivation or anhedonia that we're not even really attending to. And as we do that, then is there a better option? I do a lot of consulting for people with bipolar disorder, and often the better option is to cut the number of medications down. But regardless, clinical judgment is important here, but we need to challenge ourselves. Why are we prescribing something that most experts really discourage using in people with bipolar disorder, which was highlighted in this Medina paper? I do believe, despite the absence of a national strategy in general for most things in healthcare, that by attending to our own biases and by keeping a close watch on our prescribing patterns, asking questions of what we're doing, we can self-correct much of the inequities that we see in mental health care. Some of it is built into just systemic racism in our culture that's much harder for us to tackle and can be overwhelming. But managing my individual practice is something that I know I can do. And so I would ask everyone who's watching today to think about that. I mean, I really do believe that we can change how these kind of things happen, and that future reports from groups like the one at Mount Sinai and others can see this inequity go away. And so today, my challenge for all of us is to look at how we prescribe and practice and try to avoid bias whenever we can. And in this case, really challenge why are we using these medications that probably aren't a great choice for people with bipolar disorder. So anyway, I hope that this has been instructive and helpful, and I thank you, all of you who come and look at these videos that I do. I appreciate your ongoing support, questions, and comments. And so thank you very much. Bye.